we have this, again, this vast expenditure of energy, this surge of fight or flight energy. And then in that moment, it's compressed and it's held in check. Now, if that energy would be released too quickly, it would be overwhelming. Again, one of the reasons I think, one of the drives for people to use the opioids is to prevent this from happening, because that can be overwhelming. So in somatic experiencing, the approach here, instead of releasing this bound energy, this compressed energy all at once, which would be a chaotic expression, which would overwhelm the person, what we do in somatic experiencing, somatic meaning body, body sensations, and my understanding is that many of you are cognitively oriented, like CBT and CPT, that kind of stuff, which are basically top-down approaches, which can be helpful. But until you change this underlying pattern, which is driving the addiction, through what I call bottom-up processing, that drive to medicate is going to remain. And again, I think CBT and those kind of things are very useful in working with triggers for, for relapse and those kind of things. But to really shift out of that opioid-driven physiological state, we need to be able to work with the body sensations. And in doing that, instead of chaotically and abruptly releasing all of this fight or flight energy, again, remember, you saw the gazelle is laying there motionless, and then and impervious to pain. It's being chewed on. There's no response. There's no yelping. There's nothing like that. As it flips over, it goes immediately back into this fight or flight energy. Well, we humans don't do that. We don't go into fight or flight yet generally. We, again, get stuck with either this chaotic energy or this shutdown of activation. So the key in my approach in somatic experiencing is to release this fight or flight energy one small amount at a time. And so in doing that, the person is able to experience the sensations that take them out of immobility and bring them back into life. A typical response that a person gets is they say, I feel alive. I feel alive, sometimes for the first time in my life, people will say, because their access, because its energy has been totally shut down. And again, this is reinforced by the use of most, I think, all addictive drugs, really. So that's really kind of the basic idea. Let's see, what else do I want to say? Yeah. So also, when there's been a deep dysregulation of the nervous system, due, for example, to birth stress and birth trauma. We don't know if the opioids are released there, but that does already sensitize the nervous system to be more likely to go into a shutdown state. Indeed, that's when cesareans are generally done, when the heart rate not is increasing to a high level, but is decreasing to a very low level. And that's again when the obstetrician may feel that there's enough danger to suffice to do a cesarean extraction. So again, right, even at the very beginning, at birth, we can become sensitized. One of the things that I noticed is that people who had these kind of birth stress traumas were very likely to be using opioids. Very likely to be opioids, again, as a way to try to help them to regulate, to self-regulate. But again, until they can actually regulate, the chemical substances only give the appearance or the momentary appearance uh, of regulation. And another key concept in somatic experiencing that helps people deal with these difficult sensations that are related to trauma and that would bring them out of the immobility response is this little demonstration over here. And so this is a maximally constricted state. This is an expanded state. So when you start working with a person, particularly a person, when they've detoxed and they're beginning to be able to access sensations and feelings, that when they actually contact the sensations for the first time, it feels worse. There's a greater contraction. But as they're gently guided, this contraction then leads to an expansion. This expansion leads to another contraction, but not as far, which leads to another expansion and another contraction, but not as far, and another expansion. And again, brings the person back to life. And I don't think that any addiction treatment is going to be long lasting until the person is able to experience their own life energy, their own life force, their own sense of vitality, and what I call healthy aggression. So if you like, we can do a little exercise to have some contact with some of these different kinds of sensations of aliveness. And I'm going to demonstrate it to you. And if you don't want to do this, of course, please don't do it. Actually, you can even imagine doing it as I'm doing it. But if you want to do this exercise, it could be somewhat illuminating. So the idea, are you for that? Okay, good. Let's do it. Okay. So I'm going to take an easy, full breath, And on the exhalation, I'm going to make the sound voo, voo, as though it's coming from my belly. And I'm going to let the sound and the air all the way out. And then just let the new breath come in really on its own, filling belly and into chest, and then to repeat. So I'll do it one cycle, and then we can do it together. So, and I'll explain a little bit later why this is important in taking people out of shutdown, but let's just do it together first. So easy, full breath, I'll demonstrate. When I feel the vibration here in my belly. Let the breath come in, filling belly and chest. Let the breath come in. One more. Wonderful, great. And just rest and notice your body sensations. Hands, fingers, feet, breath, chest, belly. I notice some of you are moving a little bit, stretching, which is a typical reaction. Yawning often occurs. So what are some of the things that you noticed in doing the exercise? Anybody willing to say?
Awareness of body movement while the breath was going in and inhale and exhale.
Okay, great.
Like a connection to groundedness, to the root.
Aha, groundedness. Okay, good.
Kind of warm up the chest to this area.
Warm at the chest area, chest and epigastrium, upper. Yes, okay. And aliveness, warmth, aliveness, yeah. Again, these are typical, and it takes some time for what for. Sometimes I do this. I'll do this, have the person rest, and do it again. Because when the client is not used to feeling body sensations, it takes a while before they begin to be able to access them. The shutdown state is I think is what's often described as alexithymia, an inability to have sensations and feelings, and to even put words to those sensations and feelings. So let me tell you a little bit about the psychophysiology of this little exercise. There's a nerve called the vagus nerve, and it's the longest nerve, and it's the largest nerve. Actually, I'm not sure if it's the longest nerve. It's definitely the largest nerve in the body. Vastly more neurons than any other nerve. And what happens when you're exposed to something that's overwhelming or that's horrifying? Say you go out after this meeting and there's a poor kid is hit on a bicycle and he's laying there on the ground, and you get this turning in your gut. That's the vagus nerve. That's the efferent, or the motor part of the vagus nerve. It's also, again, the system that releases the endorphins. It's part of that overall system. So now what happens, because, and this is my very dear friend and colleague Stephen Porges, went through some of the early literature, the anatomical literature. Actually, Darwin said the same thing, that the great majority, between 80 and 90% of this nerve is afferent. So it's taking sensory information from the gut. And I think you all know that the gut has supposedly its own brain, and the enteric brain that's as complicated as a cat's brain, or has as many neurons. But it's not like a brain. It's like a diffuse network, more like a jellyfish or a sea anemone, something like that. And all of that information from the gut is sent up through these sensory receptors, sent up back into a different nuclei, the nucleus solitarius in the brainstem, which then inhibits the efferent, the motor vagus nerve. So it says instead. So what happens is, if you see this horrible thing, your guts contract. That sends a message up through the vagus nerve that said, this is horrible. So then the vagus nerve sends back more impulses saying, this is not, this is, oh. And so you have what I call a positive feedback loop with negative consequences. So the sensations and the feelings get worse and worse until we can interrupt that cycle. And this exercise is the beginning towards doing that, because you're vibrating these sounds in the gut and sending up new messages to the brain system to downregulate that shutdown state. And again, you have to do this gradually because of that compressed energy. Again, we don't want that energy to be released prematurely, so we titrate this experience. And this is a major difference between the approach that I'm presenting here and some of the things like for exposure therapy. And usually I don't comment on other therapies, but that's one thing that does deeply concern me, is the having people just relive the traumas over and over again, because again, with this flooding, you get this often chaotic release. And to the nervous system, being overwhelmed is by your present sensations and feelings, emotions, is no different than being overwhelmed in the trauma. And so that runs the risk of re-traumatization. So again, my advice is, when you're working sensorially, when you're working affectively, it's really important, it's critical not to overwhelm the person. And again, when they're overwhelmed, what are they going to most likely do to try to manage that overwhelm? Yes, of course, they're going to use the substance. And again, in this case, the opioids. There's one other thought that I have to give you about different addiction to different substances. So the first few months of life have to do with the parents holding the child, rocking the child, soothing the child, helping them learn to regulate, eventually to begin to regulate themselves. Because at first, an infant cannot really, has minimum ability to regulate itself. Basically, it regulates itself by, by screaming and crying and flailing till the caregiver picks them up and holds them and rocks them and soothes them. So it's actually pretty remarkable that they are able to do that. So, so gradually, as they are able to more regulate, you'll see that the caregivers, the parents, are usually then kind of actually get the kids more excited. They play with them. They do peekaboo. They hide their face and then show their face. They see that they hold the baby up in the air. It just loves that excitement. And that culminates around 18 months of age when a new neurochemical system comes into play, and that's the dopamine system. And, this is when the child gets up and stands on its own feet and sees the world in a completely different way and is able to move from place to place. And there's that door, and it goes to that open door and explores what's on the other side of it. It also explores everything that it can, literally everything it can. People, there's the expression of a child-proof your home. Well, I say good luck, because that drive to explore is boundless and is mediated by dopamine. And that's, again, the new neurochemical. And one of the things that I've noticed in my generation, parents were advised never to pick up the children when they're crying, because they would only learn to manipulate you and become dependent. And they also advocated against breastfeeding as it was unsanitary. So this is really horrific and really led to a lot of, addictive tendencies towards the opioids. Now, what I see also happening is when the 18-month-old, the 2-year-old, is into everything, and the parents have to stop them. And the parents of these generations, the millennial generations, for example, tend to want to be the child's best friend or to reason with a child. I mean, have you ever seen somebody try to reason with a 2-year-old? Right? Yeah. It's just not possible. It really is not possible. So anyhow, because these boundaries are not set, the child feels this incredible inflation. It's like, I can do anything. I call it the world be me oyster stage. And again, they need the constraints because they can endanger themselves. They need to hear, stop, you can't do this. You're loved. It's not that you're bad, but this action is not okay. And it has such a powerful effect of stopping that. So they go from this inflated to a deflated. This is sometimes called the narcissistic inflation, the narcissistic deflation. Thank you. And that, I mean, you probably are thinking ahead, that where these boundaries are not set, I believe, and I don't have really data except anecdotal data, but I believe my experience is that these people are very often attracted to dopaminergic agonists, i.e. cocaine, because it gives them that feeling of, I can do anything. So again, this is a kind of a brief overview of a little bit of bottom-up processing, of working with sensate experiences, body experiences, and then opening to these sensations, these arousal sensations, very gradually titrating them, not overwhelming the person. Because again, if the person is overwhelmed, they're going to have the need, the urge to medicate the overwhelm. Particularly when, outside of the treatment, well, let's just say when the treatment is completed and they experience overwhelming sensations, because if you work with overwhelm, you're reinforcing the overwhelming experience. It's likely that the person will continue to do that as a way of attempting to release. But again, they're overwhelmed by it, and then are impulsed to use the narcotics or perhaps even stimulants. So that's kind of the brief overview. And I'm wondering if you have some questions that you'd like to ask. Or Kurt, I know that you were going to say some things. Is there something that you're wanting to add as well?
I think I would appreciate if people ask some questions, because I will jump in exactly the same topic, and the experience is exactly the same thing. Like we sitting together 20 years ago, and he's in your flat drinking tea when we talked about neuroanatomy. So that's the one part. But I think the question of the people, of the group, that could be very helpful. And I will take that in my talk.
Okay. Okay, so I'll take questions. I don't know if you have a microphone that can go around, because when I hear it here, it sounds very muffled. So please, I invite you for questions or comments. I mean, if there's something that you think that I might, that you might want to add. Okay, I see somebody standing. Hold the microphone.
Yeah, I'm just holding the microphone so I can give it to people who want to speak.
I am sorry, I could not hear the question.
Hello, Peter? Can you hear me?
Yes, I can hear you, but it's very muffled.
Okay, maybe should I come and stand there so you can see me?
So speak, actually hold the microphone
Okay,
really
is that
close
better?
to your mouth.
Yeah, can you hear me now?
A little bit better, yeah.
Yeah, I was just going to say I came across your work last year and tried the exercise you did with us today, and it had a very significant effect for me. So I continued exploring the body releasing and started to learn TRE. Can you hear me?
No, I'm sorry, I hear every occasional word, but it's so muffled. Justin, can you maybe hear the question? I'm going to just give this to Justin for a minute and then ask the question.
Our apologies, everyone. But just, go ahead and repeat the question for me.
Can you hear me?
I can hear you just fine.
Okay, so... No, I was just going to say that I came to explore somatic experiencing last year through coming from a life coaching therapy background.
Experiencing last year from a life coaching background.
And that was supporting my work in including the body in the experience and in the learning and the development. And now using
learning of the body and in development.
And now learning TRE as well. And your comment just now about the slow release and how people can become addicted or needing that faster release resonated a lot with me. So not a question, but a comment.
I think that's absolutely right, because again, when you have this abrupt exposure, this very powerful exposure, again, you're actually releasing these catecholamines and endorphins in the release. So the person wants to do that more and more because, again, they're getting the cocktails. But again, the problem with this is then it's limiting to how much they are actually able to release by doing this. And so again, there's probably going to be a greater likelihood to go for exogenous opioids and possibly stimulants.
Thank you.
Yeah, I could hear you better because you were holding it real close here. But let's try again.
Okay, so
But again, yeah, go ahead.
so are you saying that you don't advocate something like EMDR?
Well, I think EMDR community, I think a lot of the people actually who do EMDR have also been training with us. And I think they're incorporating more and more, resources and things like that. So I think it's evolved. But again, I think it depends very much on the practitioner, on their skill level, and their appreciation also that the person is not just their traumas. There's a whole world that's going in inside of every person. And I think the gift that therapy can bring is to help the people discover their own gifts, their own capacities, not just that they're erasing the trauma. So I believe that EMDR is people who are doing it are doing more of this kind of thing and also doing more binaural tapping instead of just the eye, because the eye work can be overwhelming. There's no question about that. But again, I think that all of these things are evolving, and one of the forces I believe in this evolution is an understanding of the role of the body, and particularly of being able to work bottom up with sensations.
Hi, Peter. First of all, I wanted to give some praise and thanks to your work. I think it's really groundbreaking and really needed in this work. But I wanted to ask, why is it you think that there isn't more uptake in the mainstream for a more body-centered approach?
Well, I think that's happening. I mean, I really do. I think when I first started to begin to develop the work in the early 70s, and if I gave a public lecture, I think people were, they either just had no idea what I was talking about, or they were horrified. And in now 2018, I think that, that this is over. This is no longer fringe work, but has entered the mainstream. If you look at the number of articles written on not only mindfulness, but interoception in general, you see it really has entered the mainstream. Actually, we did an article on interoception and proprioception as a basis for trauma therapies. So I would say it's in the zeitgeist. It's in the Gestalten right now, and I think it's only going to evolve and increase and proliferate as more and more people become exposed to these kinds of ways of working. So I think it's and my good friend and a colleague, Bessel van der Kolk, and his book that came out a year or two ago, The Body Keeps the Score. Again, it's so much about the centrality of the body. And Robert Scare, a neurologist who was a student of mine, wrote two really, really good books. One called The Body Bears the Burden and The Trauma Spectrum. So I think at this point, the genie's out of the jar, let's say. And I don't think it's going to get put back in. And I think, again, what it does is it offers people who have diverse approaches, whether they're cognitive approaches or whether they're psychodynamic or psychoanalytic. All of these processes really are enhanced by being able to reference them in the body. Indeed, this is what Eugene Gendlin, PhD thesis was. He was the person who coined the term focusing. And he tried to find out which therapies were the best therapies for people, to improve with their symptoms or whatever. And he didn't find a very strong correlation. So then he thought, well, maybe it was the experience of the therapist. How many years whether they were PhD or masters or bachelors. And that didn't make any correlation. Actually, I think there was maybe a little inverse correlation. Then he thought, well, maybe it was the particular therapist, and there was some correlation there. But the only thing that had robust correlation is that the people who really improved in psychotherapy were the people that were able to reference their bodily experiences. So, again, this is really enriches any form of therapy or education.
Hi, Peter. I'm not sure you can see me. Just to go off on a bit of a tangent here, I'm not sure if it was yourself or Kurt was mentioned in the bio as regards working with sports teams. Would this brand of therapy be helpful? I presume it would. Or how would it manifest in dealing with perceived trauma, i.e. doing badly at something, a bad play at football or a missed putt, or in the future, a perceived lack of survival or fear?
Right. Well, again, I think performance is very much, there are connections, of course, with performance and childhood trauma. I mean, sometimes people are highly motivated, in a way because of their trauma, but then often it ends in some kind of disaster. There's a movie that just came out, a few months ago called I, Tanya, about Tanya Harding. And she had this horrific, traumatic childhood. She had the mother from hell. And, she discovered this one talent of skating. And she was able to do the triple axel that had never been done, or at least never had been done in Olympic competition. But then her trauma led to her complete downfall as her husband set up the situation where they hit Nancy Kerrigan in the knee with a sticks, and that again everything fell apart. So you have seen that it's a highly motivator, but then often it just leads to tragedy. We also actually just recently did an interesting workshop called Trauma and the Performing Artist. Actually, we're going to be doing that in London, I think sometime in August, for performers, actors, musicians, directors, writers, and therapists who work with people in the arts. And what was very interesting, again, people are motivated, probably in many cases, by their trauma. And so what we would do is have a person do some kind of a presentation, whether it was a musical instrument or a monologue or some kind of a dance thing. And we would kind of analyze. I was doing it with a student of mine, a colleague of mine, Betsy Politan, wrote The Actor's Secret. And we would then do some work with the person to kind of get them a little bit unhooked from some of the trauma. And then they would play again the performance. And so it was entirely different. It became, instead of them doing a performance, you were engaged with them as a real person. And you see shows that are able to do this. My personal favorite is one that comes from you Brits called Call the Midwife. And it's just a wonderful combination of actors being able to access their affective nuances and to work together in a team, along with brilliant writing and directing. And right now, my video recorder at home is recording that, so when I return, I'll be able to do the last two episodes. But anyhow, And I pray that there'll be another season. But again, but getting back to your question about performance, I think, again, performance can be a motivator, but there's a pitfall, there's a trap, and that is the trauma. And when you're able to release that, to open that, then I think they perform in a different way. You see the flow, you see the poetry in some of the professional athletes, and I think they're more likely to be supported in that way.
Peter, thank you so much. It remains for me to say, sadly, we've run out of time for any further questions from you, but I'm sure if we could, we'd listen to you all evening. And I just like to say that this whole experience has gone brilliantly, not just because of how well the live link up has worked, but really just because we are listening to you and hearing the things you say. So I'd like to ask people to show their appreciation to Peter.
Thank you. Thank you. And I guess I give it over to you, Kurt. Is that what we do here now?
That's it, yes. Thank you very much, Peter, indeed.